Okay, so we're going to talk about abdominal trauma. Something that should be near and dear to your heart, even if you're never going to do trauma. I turn every case that you get into a trauma case, and then you start thinking like trauma. If you have a perforated gastroduodenal ulcer, and that patient has contamination in their abdomen as well as a hole in their bowel, and they're doing crappy, and they're bleeding, and they're cold, and they're all that. Stop thinking about it as a perforated gastroduodenal ulcer or just duodenal ulcer. Start thinking about it as he just got shot through his duodenum, and then your brain will start kicking into keep him warm, give them real blood, give them platelets, get off the table as fast as you can, think about damage control, what are my ways out? So even though it hates me, so even though it's not trauma that you're doing most of the time, think about it being trauma, okay? Same thing with the liver. Has anybody ever jammed a trocar through a liver? Anybody jam it? When you grab the fundus of the gallbladder, you're pushing it up to get that exposure, and it slips right off that gallbladder, and it goes right through the liver? You've done that? If you ain't done enough yet. It's going to happen. Again, now it's a trauma case. All right, we talk about zones. Jean-Luc, these are your zones that you were concerned about. What are they?
Zone 1's great vessels, IVC, the aorta, perinephric zones, left and right, pericardial gutters, and then the pelvis, zone 3.
Zone 3. All right. So, what do you have to do with zone 1 when you have penetrating injury to zone 1?
Explore.
You have to explore. Why do you think you have to explore?
Big bad things there you don't want to injure.
Things. The aorta, the vena cava, the pancreas, duodenum, all those things live in that zone 1. So that centralized system, you need to make sure that if you have an injury here, you got to go look for where that bullet went or where that knife went. What about zone 2 there, John? So is it obligated to explore every one of those?
No. Well, if it's penetrating, typically, I know we've talked about this,
Yeah.
not always, but the book answer is yes.
So the book answer, so when they ask you on your test and they ask you in that room, you have a penetrating injury to the kidney, you should explore it. I'll tell you that I don't, unless it's actively bleeding or there's an enlarging hematoma. Because 9 times out of 10, that thing will just stop. And having the ability to do a lot of trauma and not a lot of facilities, you end up watching a lot of stuff that the book doesn't say to do, and people turn out fine. So I don't know who wrote the book. And then the pelvic fractures. This is the worst injury. I hate this injury, right?
As a Christian.
Oh, who, Eris?
Sorry, just a quick question. Like penetrating, like knife versus like ballistics, like, do you think the gun they also stock as well? Just
Yeah. Yeah, we have one right now that blew the apex of the kidney apart. There's no extravasation. The bottom hole of the kidney is actively being infused or perfused, and there's no evidence of injury to the hilum, so it's good. Now, a central hilar injury, you might as well take the kidney out. If you knocked out the blood supply, that's why a CT scan is really good. If that kidney lights up, you know it's getting blood. If the kidney's not lighting up, then you're like, well, it's dead. Now what do? You just watch it and see if it goes bad and then take it out later? That's a judgment call then. So the ones that we struggle with, probably the worst, at least I do, is that, this little guy that's down here, the vena cava, and then you have that internal iliac. That one it gets to, it takes a while to get to it. You bleed like stink. The vessel's as big as your finger and it stays open because of the tissue around it. Gunshot wound down there is a bad day. But again, we try to stay out of the pelvis, right? Because if you pelvic fracture, get in that hematoma, at least that's what we used to think. Now we're like, screw that, we'll just pack it and get away from relying on IR. And why is that, Eris? Why do we do that? Why can you pack instead of going to IR?
low pressure state.
Well,
Injuries to the pelvis.
yeah, so what's percentage is arterial versus venous in the pelvis?
Majority are venous.
Yeah. So you're about 10% arterial and the rest are venous. So if you pack your pelvis, you'll have an effect on that. All right. Oh, that's not going to... Anyway, you guys should have already read all this. I'm just here as your advisor. The fact is that these algorithms are everywhere, and if you don't know these algorithms, then you should look at them. All right? This is how you explore an abdomen. Dr. Willard Go through your steps like you were dictating the expiration of an abdomen.
So, vertical midline incision. Gave the, okay, so
We're in a room someplace in San Francisco.
Okay. Vertical midline incision down to the fascia. And swiftly get to the fascial layer and open the peritoneal cavity with sharp dissection. So, depending on the injury, make a generous incision, like almost side forward to settle
So this is the difference between you. Amos, go ahead and tell me how you would dictate your exploration and how you enter the abdomen.
So make a midline incision, get in, evacuate the hematoma, go ahead and start packing off the liver, the paracolic udders, and the pelvis. And my laps, once I allow for anesthesia to catch up, resuscitate as I evacuate that hematoma. Once that's done, then I would begin exploring my zones. I'd look at superceliac zone 1. If there's any bowel spillage or succus or hematoma, then I'd look at zone 1 inframesocolon. I'd pull it up to the transverse colon, looking at that area. Then I would continue on with my exploration. See if there's any zone 2 hematomas, and then obviously zone 3 in the same fashion. Then control that however necessary, depending on what you saw.
Yeah. So that's written down. You should memorize it, how you do it, because then because you're going to dictate it every time. And this program does enough trauma. You're doing 2,400 admissions a year. We're doing 28% penetrating trauma. We're getting a gunshot wound or a penetrating injury every other day, which is busier than most places throughout the entire country. Not even Jackson Memorial is doing it. So this is a busy place. You should make sure you're picking up on the trauma aspect of it. But that's where you're at that level. Now you just have to go, how do I get to that level? Then you steal one of his dictation reports, and then you memorize his dictation. That's what we used to do, hand them around. All right. So there's different methodologies you can do. So first thing I always do is get in the abdomen, and you get there fast. I don't use cautery. If you've operated with me before, I'll usually get down to the fascia, make an incision in the fascia, and then I'll take Mayos and I'll run them up and I'll run them down. But it depends on how fast you get in. Now, if you're just doing a tentative rush roll, then take your time. But if you need to get in there right now, then use Mayos, split the fascia, do the whole thing. Immediately eviscerate the bowel. Get the clot out, like Amos said, start packing. And usually you can tell where the blood's coming from. If you can't, you're going to pack all 4 quadrants anyway. But pack where you think it's bleeding first so you can control that contamination, that hemorrhage. And then pack the rest of the way. And then when you unpack, when you're starting to do your exploration, usually by that time you're waiting for them to warm up, catch up with blood. So you run the small bowel, run the colon, and then you start looking for everything else. And you start addressing those things as you're going around. So if you wanted to get a duodenal, you're concerned that the pancreatic head was injured. Chad, what maneuver do you do to get to see that?
You go into the greater side, the western side.
Okay, so now you're worried about the head though.
Oh, you need the coca maneuver.
Okay, and what would that be?
Where you mobilize the second part of the duodenum immediately to free it up and then.
Can you just go to the coca maneuver, or what do you have to do first? What's that? Mobilize the right colon, because that's the first step to it. Pull it down out of the way, and then what you should be seeing is a duodenum. If you guys do your elective colectomies, you run into that crap, and you're like, holy crap, I didn't know the duodenum was right there. It's right there. So you rotate it around. Then you're going to do a blunt and sharp dissection to get that duodenum up and look behind it. So if you see a wound on the anterior surface of it, you have to ensure that the wound doesn't go all the way through the duodenum to the other side. And the only piece of bowel really that you can't see like that is the duodenum. So you have to mobilize it to look at it so that you make sure it's not wounded through. Okay. Yeah.
Hey,
All right.
Dr. Wertin,
Yeah.
I don't think if there's a volume button on the mic or if it can be moved a little closer to, we're having a little trouble hearing most of what you said.
Let's see here. Well, but you know it already.
For the others. That's better, thank you.
Oh, I love it. All right, now I'm going to be amplified. All right, the different rotations that we'll talk about those, the different exploration portions of it. But the reality is that you're looking to stop bleeding, stop contamination, find out where you're at, figure out where the bullet went. All right, so they want you to go through these grading things. I do not use a grading thing when I'm in there, when I'm doing an operation. I do not look at the stomach and go, well, that's a grade 3. I'm going to go ahead and do this operation. What I look at is how destructive is the injury, is how best to repair it, and then how safe is it for the repair for this patient. The gastric injuries are usually pretty safe to repair no matter how you do it. It's well vascularized, it's really nice and thick. Usually you can't mess that up, okay? I've seen people mess it up, but you know, it's one of those things. You can do a primary repair with a stitch, you can do a staple. I use a stapler, I just slam a GI 75 across it. You want to use a green load, use a green load. You know, I grew up using blue loads and never had a problem, so whatever you need to do. But they're going to get to, you know, a total has anybody done a total gastrectomy in trauma? You know, they have that. It's like grade, 8? I don't know what it is. It's ridiculous, you know, because what would cause that? Well, an AK-47 going through your stomach will blow it apart, but you can still put that back together. You'll just do a resection, do a gastric sleeve or whatever else. And let's see, you know, in your bailout procedures, what do? You do a Roux-Y, you do a Bill Roth, you know, where you just pull up some small bowel to it. So if you need to control that, you know, so they can still eat. And the other thing is when you see upper GI trauma, to start thinking about placing an NG tube or something that you're going to be able to feed them with in that first operation so they can start getting nutrition. Tricks of the trade there. But again, they want you to think about doing these big badass operations, and it's not going to happen. So we think differently than most people. Like if you go in to do a Whipple with an oncologic surgeon, it's very meticulous, it's very taken down. They're focused on the operation they're there for. They need to get negative margins, et cetera, et cetera. I'm there to say what is the least amount I can do and still get out of the operating room. And time under anesthesia definitely affects the patient. I'm sure you've all seen that. You have a difficult case that goes a long time, you'll see people that don't do very well. Small bowel injury. You know, it's up to you. If there's multiple holes in a short distance, you know that distance usually is 10 centimeters, cut it out. Do an anastomosis. It's better than repairing each one. My experience with the only time that I've opened somebody up and I couldn't do a damn thing for him. A guy got shot 5 times. He was a bad guy. Guy came around the wall. The good guy was pretty good at his job, and stitched him up 5 times across his abdomen with a M4. And I opened his abdomen up, and it was just blood and bowel and everything everywhere. And I'm like, oh my God. And I'm like, I don't even know what to do with that, because there was so much intestine that was destroyed. And he was bleeding from his vena cava, and I stopped the vena cava bleed by that great stitch that you just put down there blindly and it stops. Woo! But you got to look at the bowel repair for these people is make sure that they're stable. All these things are predicated on the stability. The older surgeons, when I was coming up, we used to stay in the operating room until their blood turned to Kool-Aid, because they'd say stuff like, I'm not coming back tomorrow, what I should have done today. I've never, you know, all these things. It's a different patient population. Trauma patients are totally unstable, and they're going to crap on you, and they will not take a joke. So we leave a lot of people open, probably more than we should. But we want to make sure that we don't put together somebody who's not doing well. Because there's nothing worse than putting an anastomosis, Chad, and then putting them on Levophed. It makes me cringe. You're just like, oh, Lord, Jesus is going to die. So again, make sure that you're looking at the destructive lesion. Look at it. You can tell. You can look at it and go like, yeah, I can put that back together, or that's ratty. I think I'm going to leave that alone. You know, if you're in the duodenum, you look at it and you go like, okay, I'm going to trim that off. Can I get it closed? Okay, maybe I need to throw a piece of bowel on it. So those are the things you got to think about. And again, I don't use a grading scale to do that. This is all done for research and all done so that when I call Chad, when I'm transferring him from Monroe, and I go, I got a guy with a type 4 duodenal, injury, he knows exactly what I'm talking about. But other than that, it doesn't really help. Unless you guys have seen something different. Do we ever go, that's a grade 4? Maybe when you're doing a spleen so you can justify taking it out, but other than that, no. How do you close it? I close in one layer. I don't use the mucosa. It's all seromuscular bite. I do a single interrupted, multiple, three-ovicral. You choose the way you want to do it when you leave. But I've done it every which way you can, and they all leak, so pick the one you like the best and then deal with the problems that come with it. I never limber anything. I think limber causes ischemia, especially in a patient who is tenuous at best. If you want to do that in your elective colectomy that you prep the patient for, adequately resuscitated and did not stress the day before, go ahead. But for my patients, I won't do it because I'm begging those little vasovisorum and all that stuff to actually work and get blood to the the exterior portion of the bowel. So, and I learned that from the Brits, even if you say the Brits don't have anything good to offer. I don't think they know how to do trauma, but they do know how to put bowel back together. They've been doing it a few hundred years, and maybe longer than we have. All right. So the difference between closing in a transverse versus, if you think you're going to narrow the bowel, it just all makes sense. It's common sense, right? If you're going to make it narrow, cut it out. Oh, Jesus. I'm colorblind, so that red really screws that up for me. This is the pancreas. So let's talk about pancreatic injuries. So what is the big thing that goes with a pancreatic injury, McDaniel? What do you want to know?
You talking penetrating trauma?
Any kind of trauma. Blunt, penetrating.
The SMA, the aorta, the leak, duodenum, all the stuff in that area. There's a lot of things.
Yeah.
Bile leak.
The list goes on and on. How about if we just focus on just the pancreas, then we would say, what is the integrity of the pancreatic duct? So does the duct been fractured? So a blood trauma can cause that to break that tail of that pancreas too. A gunshot wound to the pancreas can cause that as well. And so then you have to look at where is the injury. So if we're thinking of it as a penetrating trauma, you're going to take it wherever that injury is. And it's kind of fits that same premise we use in oncology, where if the head of mass of the pancreas is where it's at, then you're going to have to do a Whipple. If it's a tail, then you can just take out the tail. They talk about doing these splenic preserving pancreatectomies, but that ain't going to happen. You just rip the whole thing out and call it even. The best time to do it is when you acutely know about it. Doing it 7 days later sucks. Haven't done that too. So the big thing is duct integrity. And so there's different ways to determine duct integrity. So if you just have a hematoma on the pancreas, you're not really going to have to go after it. So there's a couple different ways you can identify whether or not there's an injury to the duct. The easiest way is MRCP, right? You just get an MRCP, but now you've got them X-fixed and there's rods and everything, and everybody's like, oh, you can't put those in the MRI. And you go, no, they're MRI compatible. And then you go, okay, fine, don't do it. Then you can do an ERCP, or you can do welcome. Dr. Cox is here. We can start. No. You're fine. So anyway, the reality is that there's no room for repair for pancreatic if the duct's injured. Just take it.
Just like on this, in the oral boards, they give you this scenario that shocks to the pancreatic head, and then they tell you to go.
Yeah.
So you may want to, I think it's, as you said, grades are for books,
Yeah.
but they want to listen to the practical management, so that's a very common scenario they get. They will ask you, that, you know how it is,
Yeah.
go for it. And
Yeah, we just shot this guy in the pancreas. So the head of the pancreatic injury to the gunshot wound straight through the head. Well, the first thing you got to worry about is everything that's sitting behind it, just like Dr. McDaniel said. The SMA, the SMB, the portal could be in the area depending on the process of where the gunshot went. The bile ducts are all there. So the only operation you can do, if it's a destructive injury, is doing a Whipple. And so now you're left there doing a Whipple in the face of somebody who's not doing well. Because usually they don't do well when they get a gunshot wound to the pancreas. We call it a wound to the soul. That's in that book. Top knife. It's a wound to the soul. Because it's hard to get to, and there's a lot of things that go through there.
You really feel your soul when you're in no arms.
You'll feel a little more than that. So do you do a Whipple in the first go? Was that Harris?
If they're perfectly stable.
If they're perfectly stable.
What's up, let me look at that.
Yeah.
But the answer, unfortunately, is no.
No. Draining it out of there. So repair what you need to repair. Again, control contamination, control bleeding, control the things that are killing the patient right now, and come back and live to fight another day. And even if you wanted to say, hey, this is what I do, a temporizing procedure, I then call my biliopancreatic guy to come help me do the next operation so we can complete this Whipple. But the things that you have to worry about is, what do you do for a duodenal injury? How do you take that down? When do you start doing, small bowel anastomosis? I am not doing, or you can do it, I guess. You can do a choledochogeostomy in the face of gunshot wound, but I'm not doing it. Because they don't do well when it's an elective procedure, let alone when you're trying to do that. So just think about the drains. And the worst thing you do is you're like, hey, if it's not bleeding, it's not going anywhere, throw the drains on top of it, let it ride. But also start thinking about people where you're going to want to feed them and how you can get access for that, even if that's just a Dobhoff. Colonic injuries. These have always been revisited. Everybody's been always talking about these. We do a lot of diversions, if it's a destructive lesion. If it's just a through and through wound from a low velocity gunshot wound, just repair it primarily, see what happens. It's perfectly reasonable to do that. If it's a destructive lesion, meaning it's greater than 50%, you should just do the resection and put it back together. Now the question is, do you put them back together and walk out, or do you divert them, do a Hartman's, do you do an endoileostomy or a loop ileostomy, primary anastomosis? All those things are still dependent on the patient's physiology. So if the patient's not doing well, then do the safest procedure you can. Do what fails well. People who don't take a joke cannot have hey, that anastomosis looked really cool until it broke down 3 days later and then they died of sepsis. You know what, that ostomy looked fine and the patient left and came back in 6 months and we put them back together. So make sure you pick an operation that's going to fail well for your patient. And that may mean that we're operating on Awe, and Awe can take anything. I put his ass together right now. Not even put a loop on him. We'll take a shot. Compare him to 300-pound insulin-dependent diabetic who has everything else going on. Totally two different people, two different organisms. So always look at how the patient's doing, how much blood they've given them. They just had another paper come out saying, yeah, it's still safe to do primary anastomosis with a loop ileostomy if you're concerned about it, if you're concerned about the anastomosis. If not, you throw them back together and you let it ride.
This was my oral board scenario. Stents of partial thickness, like destructive, non-destructive. Will I put it together or not put it together? So this is very important for the chiefs.
So that's the thing that we're trying to go through this migration of, if you hung around medicine long enough, you start to see it change as far as what we're doing. It's kind of like the head injuries that we're seeing. People finally have enough data to go, hey, look, there's a set of head injuries that we don't do anything for. They need to not be admitted to the hospital. So now the literature's starting to catch up with that so that we can stop admitting an 89-year-old to GCS 15 with a dot of blood in her head. Okay, that's safe to do. And then they keep pushing forward, like pre-sacral drainage. Well, you probably don't need to do that. Just wash them out and divert them, and they'll be okay. You don't need to do this massive destructive procedure to get through it. But we always start on the very safest, most destructive thing, and then we start cranking it back. Halstead started doing his mastectomies, his radical mastectomies back in 1820s or 30s or something like that, and it took us until 2000 before we started doing breast conservation therapy, where we said not every woman needs a mastectomy. Not every woman needs to have her axillary nose pulled out, but it's taken 60, 70, 80 years to get to the point where we can say, you don't need everything for everybody. Well, and the colonic injury is the same way. You have a young, healthy dude comes in here, he's like all ripped up, tatted all up. You got a single gunshot wound from a 9mm through his colon. You're probably okay. Just put that kid together and not even worry about it. He'll do fine. And you just have to play that off the other thing. It's a lot of judgment. All right, so the pancreas, because everybody loves anatomy because we're surgeons. I just don't like the anatomy lab because it stinks. SMA, SMV, pancreas. That's why we call it a wound of the soul. I don't know. You guys ever seen the pancreas that far away from the SMA? I mean, like the duodenum, it's usually like right here. It makes it so close, so you're like, ugh, it sucks. So you can see that you can have just about everything injured. When we talk about the blood supply that goes with that, why do we take off why is the head different? Well, the blood supply is different here than different there. The splenic artery, so forth. And I don't try to save the spleen, even if the spleen's uninjured, because I just don't got time for that. Y'all need to pick one of these and memorize it, or not. Just look at it before the test. And if they go like, what's this injury pattern? You'll go like, 57, it's a 3, and this is what I should do. The fact is it's not real. And so you have to pass the test, but you also have to know what's real. Yeah, this one I like. Associated injuries that are most likely to kill the patients. Those are the things we're worrying about. And then you have to start predicting outcomes. So we have a patient right now that has half of his liver dead. So you say, what do I have to tell my team to be on the lookout for? And so you have to start predicting those injuries and what are their outcomes, what's the trajectory you're looking at, what's normal, and then what to be able to pick up what's abnormal. Because if you don't pick up on what's abnormal very soon, then you sit on a guy with a leak for 4 days versus somebody who's not. And this guy's liver's going to go crazy. He's going to get a white count. He's going to fever. He's going to do everything else. And you know what? We're not going to do anything for him. We'll just stare at him. Don't let skin, bone, anything stand in your way of exploring a wound. Bigger the better. Go big or go ugly early is what we used to say. If you're going to go ugly early, because inching a laparotomy incision while you're trying to figure out what's bleeding up there makes no sense. Just do a laparotomy. Take care of business. If you need to mobilize. Take care of everything. If you need to resect, take it. And stop. Don't second guess yourself. You start second guessing yourself, you'll have a patient that dies. Again, these are just the injuries. These are coming out of the ACS book, the red American College of Surgeons Principles of Surgery. I have the 2003 version. You know what? Didn't really change. So I got these ones offline. I was like, but these are great. I like that book because it's what they use to test you on, but it's also shows you good pictures of what's going on and how to do it. I'm going to repair here. I'm going to repair there. I'm going to resect. I'm going to do a Bill Roth 1, Bill Roth 2. And so this whole thing is to give you an idea of what to do when you get in there so you're not, your expectations when they're not met, you're able to engage and take care of the patient. It's like the story I tell about the deer. When you're driving down the road, you see the deer in the headlights and the ears are up like this and the tail's up, eyes are looking right at you, and you're driving at them at 65 miles an hour and you're like, come on deer, what the hell are you doing? Well, we get that same way if you don't have your expectations met. So you have to have so if you go in there and you go like, I'm going to do this to control the bleeding. I'm going to do a Pringle procedure. Well, that didn't work. Well, I'm going to isolate the liver, and that didn't work. And now I'm going to do a Schrock shunt. But you have to have those multiple things because if you get to the point where you can't or you don't expect what's coming, you're going to get deer in the headlights and everybody's going to stare at each other and go like, what the hell do I do now? And it still happens. I had one with, it was Jones. And let's see, was that the one? Dr. Hughes, the guy got stabbed through the liver. Dude, everything. Got the hepatic vein, got the portal vein, got the vena cava, and you've stopped one thing and blood flies out of the next thing. And after you've given him, 20 units of blood and coded him twice, you're like this isn't supposed to happen. I thought it was like, let's do the rock star stitch. Oh, it's good. And then the blood starts coming up again. You're like, God dang it. And so you just keep going down. But I didn't even think that you could hit everything if it's all lined up perfectly with a big knife. But anyway, know what you have, what you can do. But you know what's also great about trauma? You don't have to jump on any of this. You just staple that crap off, and you go home, you read a book, you come back the next day and go, this is what I'm going to do. Because nobody's telling you got to put them together right away. Then just basically a bill off too. So just know that there's different ways to hook them up. I've done a Roux-Y here. I've done a Bill Raw. I've done multiple different ones just here just because of the gunshot wounds. All right. So again, duodenal, everybody's afraid of it. I am. I hate the very first case I did in this hospital, Amos, was somebody who got stabbed in their duodenum. I'm like, how do you get stabbed in your duodenum? Very first case. So if it's a small laceration like that picture showed before, just oversew it. Repair it, put a drain over it. Drain's not going to do anything except tell you when it's leaking, so you can go back and do something else. I've had somebody primary repair, a Irish surgeon, also by the name of Tom, repaired it. He leaked, and then we ended up taking him back and doing basically doing a Roux-Y to that hole in the duodenum to be able to drain that because there was just not enough tissue to close after it leaks. So you have to have that ability to go back. And again, if the Whipple, you're going to maybe have to do a Whipple. It depends on how bad it's tore up. The blood supply of the duodenum does not like to be messed with. And so if it's destroyed, you're going to be doing a big operation. But again, take care of the contamination, take care of the bleeding, and then bail. Okay? Get the patient back, make them warm. Again, these are things you should just...
Did you notice that they are from 50%, they're down to 75 now?
Yeah.
And destructive, non-destructive.
Well, I think that,
Chronic,
oh, there's your distal pancreatectomy. Sometimes they're really nice to you and they break them and then you just staple across right at where it's broken. Yeah, no. I'll call somebody who knows more than I do about it. And then it talks about the management thing. ERCP versus MRCP versus whatever you want to do to figure out the duct's injured. And this puts them all together. So again, it's one table. You can look at it. It's in the book. You guys have access to it online. They call it the Scientific American. And you can get it through your guys' library. It comes out as a photograph. You can have it. Again, I think, in my personal professional opinion, I think it's low yield for any of this crap. But for your test and stuff that you're going to have to pass, it's actually something you need to know before you leave. All right, so the other things that come through, it talked about doing the damage control laparotomy, and what does that mean? And what that means is the patient is either unstable, meaning they're cold, they're coagulopathic, they're hypotensive, there's something that gives you the heebies that he's just not doing well or she's not doing well, and then you go, I'm just going to do the damage control part, which I'm going to resect everything, control contamination, control bleeding, and then close the abdomen temporarily with an abthera, and then get the heck out of Dodge. So you use that basically as a default. You should have to really push yourself to put somebody back together who's just exsanguinated, and you get somebody that's got 2 liters of blood that falls out on the ground, and they look great, but you got to talk to your anesthesia provider who's pretty much running that whole show, but you got to tell them what you want. You got to give them blood, don't give them crystalloid, be able to go. And then, how long do you leave them open? We used to just leave them open a day. You take them back the very next day, you check it out, make sure everything's okay, finish your anastomosis, and button that abdomen up. But if you give them too much crystalloid, you're not going to be able to close them. because of the amount of swelling that goes along. And that, again, you guys seen the AAAs, right? People forget that they're a trauma patient, so they give them crystalloid. And then you're like, I can't get this guy closed. And then you're playing that game. And we really saw a change of that, because I came up in the area where we gave 21 liters of crystalloid during resuscitation. We thought we were doing a good job. And then you go to war and you figure out that if you just give them blood, the very next day you can button these guys back up and they're done. So just remember that the whole thing is just a continuum of resuscitation. All you are is source control. You're not cool. You're not anything else. You get in the abdomen, you get to places where people can't put pressure. That's what we do. But the resuscitation part, all that stuff that goes with that. Without that, you have nothing. If you don't have a good anesthesiologist, you're going to do poorly. And you need to talk to your people. Even when you're just operating, just talk to them. Ask them what you want. Tell them what you want. They'll be snotty with you, and you'll go like, okay, how about you don't do that to my patient? We'll be okay. Because the first thing I always do is go, that clear fluid, that needs to get the hell out of here. Because if it's there, you guys are going to turn it on, and it's going to go in the patient, and then there'll be another one hanging. And what you do is you go, there should be blood or plasma hanging until I tell you otherwise. What's a quick move, Yoko, if you're in the operating room and your patient, you just zipped them open, got your packs in there, and the patient's hypotensive, and they're trying to catch up. What do you do?
So you could, I guess, compress on the aorta.
Yeah. Reach right up to where the lesser sac is, squeeze the aorta. You'll watch the blood pressure come up, hold it. That's cross-clamping the aorta. Wait for them to build up enough pressure, get some blood into them. So now you're perfusing the organs that need to be perfused, and then you can let it start to come off of it. So you're basically the Reboa of the abdomen. But I've seen too many times people zip them open, and they're like staring at the monitor going, well, it's 65. 65 over nothing. You're like, okay, so you're going to crack their chest, or are you just going to reach up and grab the aorta? Just reach up and grab the aorta, because their blood pressure's not high enough to push your hand off, so you can actually do that. And you can just sit there. I've done it here, and just go like, okay, guys, when you guys get blood in, let me know. And we'll be back to where we're starting. Cold. People underestimate how cold people get. There was a patient that was on medicine that didn't stay above 92 degrees her whole last day of her life. And then people wondered why she wouldn't stop bleeding from her gastric ulcer. So everybody can be a trauma patient. So just think about all those tenets of battle that goes along with the trauma patient. All right, questions? Yay, team. Oh, next week is the other part of it. We'll pull some pictures out, show you some video. They'll be gory. It'll be fun. Awesome. All right, thanks.